right, today we're tackling a really unique and kind of deceptive form of cancer, adenoid cystic carcinoma. It's rare, it's slow growing, but the way it behaves makes it one of the most persistent and relentless opponents in oncology. So let's get right into it. So let me just start by asking you a question. Imagine you find a small, firm little lump inside your mouth. The thing is, it doesn't hurt at all. You'd probably ignore it for a while, right? Maybe you'd figure it's just some minor irritation that's going to go away on its own. But what if it isn't? Because this is often exactly how it begins. What you're looking at here are two pretty typical ways this cancer can show up on the palate, the roof of your mouth. And what's wild is that the tissue on a surface, the mucosa, it looks almost completely normal. It's just this smooth, firm swelling underneath. It is so easy to see how you could just completely overlook something like this. And that really brings us to our first major point. This cancer's most dangerous quality is its deceptively simple, quiet start. So what is this stuff exactly? Well, adenoid cystic carcinoma, or ACC for short, is a rare malignant tumor. And it comes from the transformation of some very specific cells inside our salivary glands. The ones that make our saliva. Now, this is where it gets really interesting. While ACC is rare overall, it only makes up about 25% of all salivary gland cancers. It is the absolute dominant player in one very specific area, the minor salivary glands, especially the ones in the palate. So think of it this way. In this much smaller pond, it's the biggest fish by a long shot, making up 50 to 70% of all tumors found there. And the clinical features, well, they line up perfectly with what we saw in those first pictures. The number one sign is that firm, painless swelling. Now, sometimes the surface can break down and form an ulcer. And if the tumor happens to be in one of the big salivary glands, like the parotid gland in your cheek, it can even cause facial nerve palsy. But the key takeaways are that it's a fixed, distinct swelling that feels solid when you touch it. So if it starts out so quietly, so innocently, how do doctors actually unmask this infiltrator? And that's what we're covering next. The path to getting a diagnosis is pretty methodical. It always starts with a biopsy to confirm that, yep, this is cancer. Then a pathologist takes a look at the cells under a microscope. But once ACC is confirmed, that's when the real work starts. CT or MRI scans are used to map out just how far this tumor has already spread, because, as we're about to see, this is a tumor that absolutely does not like to stay in one place. And this, right here, this is the whole story. ACC is notorious for something called paraneural spread. What this means is that the cancer cells have this unique and, frankly, sinister ability to invade the sheaths around our nerves. They essentially use the body's nerve pathways as their own private highway system to travel far, far away from where the tumor first started. So why is it so good at this? It's because the tumor is unencapsulated. A lot of tumors are contained inside a fibrous capsule, almost like they're in a little bag, and that helps keep them in one place. ACC has no bag, it has no container, and this allows it to send out these microscopic little tendrils that can widely and silently infiltrate all the surrounding tissues and, most importantly, hop onto those nerve highways. This sneaky, infiltrative nature means that trying to treat it requires a really direct and aggressive approach, which leads us to what we call the surgical battle. Because this tumor spreads so widely and because microscopic cells can be left behind, the main treatment is surgery. And we're not talking about just any surgery. It requires removing the tumor with a really wide margin of what looks like healthy tissue, just to be sure you get all those invisible infiltrating cells. The main attack plan is really a two-pronged approach. You've got that wide margin surgery, and it's often followed up by radiotherapy to try and mop up any cells that might have been left behind. But what's really notable here is what doesn't work. Chemotherapy, which is such a common weapon against so many other cancers, plays almost no role in managing ACC. This is a battle that is fought almost entirely in the operating room. And all of this brings us to what is easily the most sobering part of this whole explainer. You see, despite that aggressive treatment, ACC proves to be an absolutely relentless opponent over the long haul. Now, if you just look at the 5-year survival rate, it's around 70%. And you might think, okay, that sounds reasonably optimistic. It suggests that for most patients, the initial treatment works pretty well at controlling the disease for at least a few years. But this is where the story takes a gut-wrenching turn. Look at the 15-year survival rate. It plummets to just 10%. This is the true, devastating nature of ACC. It's not about the short-term fight. It's about the long, slow, relentless march of this disease over time. And this quote just brilliantly explains why. Our source material puts it perfectly. This grim long-term outcome is a direct reflection of the tumor's fundamental behavior. It's that slow but relentless infiltration, that spread along the nerves, that allows it to come back years or even a decade or more after the first treatment seemed to have worked. So we're left with this question. It really is the central challenge that defines adenoid cystic carcinoma. It's not some explosive, fast-moving enemy. It's a patient, silent infiltrator. And that is what makes it one of the most difficult opponents to ever truly defeat.